Good morning. I would like to thank the organizers for the opportunity to present. I'm going to present or to share our work in prostate cancer bone metastases induced by FGFR1 signaling. Very briefly, prostate cancer is among the main malignancies in men and among the leading causes of cancer-related death worldwide in men. Prostate cancer is an indolent, slow-growing disease in most cases with a very high survival rate for the early stages. However, when the disease disseminates beyond the local site, the survival rate drops drastically. Prostate cancer disseminates through the lymph and blood to lymph node and bone primarily, where it typically produces bone-forming or osteoblastic metastases. Androgen deprivation therapy is the mainline therapy used for prostate cancer, and in most cases, the disease initially responds. However, eventually the disease progresses or relapses into a castrate-resistant state, as it is known, and bone is the primary site of castrate-resistant prostate cancer. At this stage, patients with advanced prostate cancer have several treatment options. However, there is no therapy that is curative, therefore representing a major clinical challenge for prostate cancer. There are several mechanisms of progression to advanced prostate cancer. Our group and others have implicated the fibrous growth factor or FGF axis in prostate cancer progression. And we have shown that a blockade of FGFRs with FGFRs are the receptors in the FGF axis. Blockade of FGFRs with a tyrosine kinase inhibitor, dovitinib, has clinical activity in a subset of patients with castrate-resistant prostate cancer and bone metastases, and anti-tumor activity in patient-derived xenografts that express high FGFR1, but no anti-tumor activity in PDX with low FGFR1. This established the clinical relevance and of FGF axis in prostate cancer therapy, in progression and therapy, and most recent reports have also implicated FGF axis as a mechanism of progression to androgen deprivation therapy and other therapies. The FGF axis is a very complex signaling pathway that typically mediates epithelial stromal interaction, and it's central to prostate and bone development. In human, it is composed by 18 FGF ligands and 4 tyrosine kinase membrane receptors and its isoforms. Downstream pathways include MAP kinase, AKT, and PLC gamma. In collaboration with Dr. Chinayan and the University of Michigan, we identified FGFR1 is the prevalent receptor in the family of the FGF axis in prostate cancer. And furthermore, we identified different tissue samples of prostate cancer express different FGFR1 isoforms. Based on the predicted protein length of the isoforms of the transcripts that we detected, we focus our studies on the two best characterized, FGFR1 alpha and FGFR1 beta. These isoforms differ in the extracellular domain, alpha having 3 Ig-like loops, while beta contains only 2 and lacks the first Ig loop due to alternative splicing of one exon, the alpha exon. With all this brief introduction, our hypothesis is that FGFR1 induces metastatic progression of prostate cancer to bone, and that FGFR1 isoforms may partly explain the typical heterogeneity observed in prostate cancer and patterns of progression due to activation of different genes and pathways in prostate cancer cells. Our aim is to study the molecular and clinical implications of FGFR1 and its isoforms in advanced prostate cancer. So we first confirmed the expression and the existence of these isoforms in two prostate cancer data sets. This is the TCGA PRA data set that contains primarily samples of treatment naive, non-metastatic primary prostate cancer. And the other database is Stand Up to Cancer that contains mainly castration-resistant prostate cancer metastatic samples of prostate cancer. We also observed that the expression or the levels of FGFR1 beta were significantly higher in TCGA compared to alpha, and there was no difference in the expression of the isoforms in Stand Up to Cancer. Strikingly, we did observe higher levels of FGFR1 in bone samples in Stand Up to Cancer compared to other metastatic sites. Therefore, this would suggest that either FGFR1 beta has more affinity for bone, or that once the cells reach the bone, they upregulate expression of FGFR1 beta. We then assess the molecular correlates associated to each of these isoforms. We did that by mining the TCGA dataset that I just mentioned. And as shown in the heat map here, we have FGFR1 ratio. So it would be FGFR1 alpha over FGFR1 alpha plus beta. And what we see is that, so to this side, we would have prevalence of alpha, and to this side, we would have prevalence of beta. And we see that the different isoforms are associated with expression of different genes and pathways. In particular, MAP kinase, that it's a known downstream target of the FGF axis, was significantly associated to FGFR1 beta. We confirmed these findings in vitro by Western blot analysis and RPPA, reverse phase protein array, of C42B and PC3 prostate cancer cell lines that we engineered to express FGFR1 alpha beta controls and treated with FGF ligands. To determine whether these different genes and pathway had implications in the biologic effect of FGFR1, we did, and because bone is our bone metastasis is our interest or our study topic, we performed femur injection in male skin mice of PC3 cells, and similar findings were observed for C42B cells of prostate cancer cells expressing alpha beta controls. We monitor by imaging, and at the end of the study, we observed that cells expressing alpha or beta had increased tumor volume compared to controls. And this was accompanied by a decrease in bone volume when the cells were expressing FGFR1 isoforms compared to the controls. When we studied at the cellular level by bone histomorphometry, we observed that only FGFR1 beta resulted in an increase in osteoclast parameters compared to controls. So this would suggest that FGFR1 beta is more suited to activate osteoclasts. We also studied the effect of FGFR1 expression in the metastatic potential of prostate cancer cells. For that, we use PC3 cells expressing alpha beta controls. We first analyzed the survival of male skin mice after intracardiac injection, and we observed that expression of FGFR1 alpha or FGFR1 beta in the cells resulted in a decreased survival of the mice compared to controls. And in an independent study, we again performed intracardiac injections and monitor the bone metastases by X-ray. PC3 cells are osteolytic, so they make it easy to identify the suspicious areas of bone metastases because they generate these notches that you can see at the X-ray, and then you can confirm by histology at the end of the study. Very strikingly, we saw that the number of mice with bone metastases for the mice injected with PC3 expressing alpha or beta was significantly higher compared to control. This was 11 out of 12 mice when the cells express FGFR1 alpha, and 6 out of 12 mice when the cells express beta, compared to 1 out of 12 mice in the controls. To assess the clinical relevance of these findings, we studied the expression of FGFR1 in prostate cancer bone metastasis human samples compared to primary prostate cancer, and we observed a significant enrichment in the expression of FGFR1 in the castrate-resistant bone metastases compared to treatment-naive primary tumors. In order to assess the mechanisms of FGFR1-induced metastases, we did RPPA of PC3 sublines. And again, this heat map depicts our findings. So these are PC3 cells expressing alpha, beta, or controls, and induced with FGF ligand. Again, we see the different isoforms alter different genes and also genes in common. Since we are trying to determine the FGFR1 induced metastasis mechanism, we focus on genes up or down regulated in common for both isoforms. When we analyze the pathways associated to these altered genes, we found that they were implicated in cell motility and addition pathways. We then focus on genes upregulated that had been implicated in cancer progression or prostate cancer, including icathirin, ladinin 1, and ephrin receptor A2. FGFR1 has been shown to directly interact with icathirin. Furthermore, icathirin and ephrin receptor A2, a multifaceted receptor, have both been implicated in prostate cancer progression. And furthermore, ephrin A2 and ladinin 1 have been reported to compose or to constitute part of the icathirin interactome. Ladinin 1 hasn't been previously studied in prostate cancer. It's a relatively uncharacterized anchoring filament protein that may mediate the association of epithelia to mesenchyme. It has been implicated in proliferation, motility of mammary tumor cells. It's a regulator of actin dynamics in response to EGF in breast cancer, and a predictor of poor prognosis in high-grade breast cancer. So we confirm that ladinin 1 is upregulated in cells overexpressing FGFR1 alpha and beta. And accordingly, and in line with FGFR1, ladinin 1 is significantly enriched in human prostate cancer bone metastases compared to primary treatment-naive non-metastatic primary tumors. We then silence AD1 in cells expressing FGFR1 beta, PC3 cells, and again monitor bone lesions by X-ray and micro-CT, and then confirm our these suspicious areas by histology. And what we found is that the number of tumors per mouse in the mice with bone metastases were significantly decreased when LAD1 was silenced in the cells expressing FGFR1 beta compared to controls that express high levels of LAD1. Furthermore, when we looked at survival by Kaplan-Meier curves, we observed an inverse association of LAD1 levels or ladinin 1 levels to survival. Therefore, higher levels of LAD1 resulted in a decrease in the survival of mice. And the significance of this was confirmed when we looked at the survival of mice injected with PC3 expressing FGFR1 beta, and therefore high levels of ladinin, as you can see in the Western blot, compared to the combined survival of the curves of the other three groups, therefore with low levels of ladinin as shown in the Western blot. These findings led us to conclude that ladinin is one of the players mediating the FGFR1 induced metastases, and therefore our schematic model and working hypothesis is that prostate cancer cells express FGFR1, and FGFR1 expression is upregulated in response to androgen deprivation therapy and other therapies, and this mediates progression to bone metastases. FGFR1 expression exists in two flavors, alpha and beta, these two isoforms that activate different genes and also genes and pathways in common. And we propose that once the prostate cancer cells reach the microvasculature of the bone marrow, they use downstream targets and of FGFR1, including ladinin, that may mediate different mechanisms such as adhesion and motility in order for prostate cancer to progress in the bone. Therefore, our conclusions and future directions are that FGFR1 drives the metastatic phenotype of prostate cancer cells to bone, that ladinin is one but not the only player implicated in FGFR1 mediated metastases, and we give insights into new FGFR1 associated gene signature in prostate cancer that we need to further work on. For this, our laboratory is home to one of the largest collection of patient-derived xenografts, or PDX, of prostate cancer, and we have recently performed, or we are working on a molecular characterization because we recently performed high throughput sequencing, including whole genome sequencing, whole exome sequencing, epigenomics, and next generation RNA sequencing. Sorry. So with all that, we can work on identifying models such as the ones shown here that express FGFR1 and different targets in order to perform studies to identify markers of progression and FGF signaling activation that will aid us in determining targets for therapeutic intervention to block prostate cancer metastases. With this, I would like to really stress how much of a team effort this is. I would like to acknowledge Dr. Nabon's laboratory members, as well as Dr. Nabon, of course, and all our collaborators inside and outside of MD Anderson. Thank you.